talking about trigger finger. Let us start with the basics. For the trigger finger condition, it is usually found in the women population 2 to 6 times more often than in men. And it also involves population aged more than 50 years old, most frequently, although not exclusive. And as for the location, most commonly the thumb is involved, with the index finger being involved the least. Usually the condition is also associated with other comorbidities such as diabetes, rheumatoid arthritis, or amyloidosis. For the trigger finger itself, it is a Stenosing Tenosynovitis caused by inflammation of the flexor tendon sheath. So the sheath that envelopes the flexor tendon becomes inflamed, and in the pathology findings we may see metaplasia, which means that there is a change of one cell form into another, in this case changing into a fibrocartilaginous tissue, and the tissue that changes is the tissues of the tendon and the pulleys. So it is important for us to discuss a little bit about the pulley system of the flexor tendons. For the pulley system of the hand, it is divided into 3 types. The first would be the annular pulley, the second would be the cruciate pulley, and the third would be the oblique pulley. Let us start with the oblique pulley. For the oblique pulley, as depicted here, we could see that it is found in the thumb region and it crosses obliquely along the proximal phalanx, and it also prevents bowstringing of the flexor tendons during thumb flexion. So it is very important to know this structure because during surgical release, this structure must be preserved. For the annular pulley, it is further divided in some literatures into a major or a minor pulley. Being said as a major pulley, the A2 and A4, they both maintain the flexor tendon in its place during finger flexion. As to say, in other words, it also prevents bowstringing of the tendon. Let us take a look at a picture here depicted by Doyle and Blythe. They have identified 4 annular and 3 cruciform pulleys in the finger. The first pulley is situated here around the metacarpophalangeal joint. A2 is around the shaft or the base of the proximal phalanx. The A3 is situated around the proximal interphalangeal joint, and the A4 is situated at the middle phalanx. And while the A2 and A4 have a crucial function to prevent bowstringing of the tendons, the A1 and A3 pulley is not so significant in its function, and therefore the release of A1 surgically, which is done in certain cases of trigger finger, will not alter any hand function. Next is the cruciform, or also known as the cruciate pulleys. They function to maintain the flexor tendon sheath's dimension. In other words, it also prevents the sheath from collapsing or expanding, and there are 3 cruciform or cruciate pulleys situated in our hand. You may find that in some reference, the division of these annular and cruciform pulleys and its depiction may be different, because some authors have also mentioned the A5 pulley situated at the distal phalangeal joint. Now let us go to the pathology. As I have mentioned before, that the condition itself causes a fibrocartilaginous metaplasia, but what actually causes it is that, especially at the A1 pulley, there is a peculiar anatomical anomaly that happens here, which is the high angular loads that occur at the distal edge of the first A1 pulley. This is due to the increased contents under the pulley, because at this level the flexor digitorum superficialis branches and the flexor digitorum profundus rises superficially. These are also mentioned by Houston and Wilson. They suggest that these are equal to pulling a multifilament strand through the eye of a needle and may be responsible for the reactive intratendinous conditions that occur around the A1 pulley. So these high loads and high contents around the A1 pulley, along with the high forces that occurs there, makes this area prone to increased friction, increased tension, and therefore pathology. And now let us go to the classification, so that we now have a common understanding of what is trigger finger. We should know what are the various types of trigger finger. As we can see here, that the basic types include the primary and the secondary type. For the primary type, the trigger finger occurs without any identifiable cause, while in secondary type we can find diabetes, gout, or sometimes even rheumatoid arthritis as the primary cause. For the severity of the trigger finger itself, usually we are using the Green classification, popularized by Green. This classification is rather useful for documentation of patients' progression in your medical record, but for the treatment, sometimes treatment cannot be guided by this classification. As we can see here that the grades are divided into 4 types, 1, 2, 3, and 4. For the type 1, the condition is showing itself with pain and tenderness along at the A1 pulley. There may be catching of the digit at the grade 2, and for the grade 3 there will be locking of the digit because of the increased swelling of the tendon along with the normal size of the tunnel that is bounded by the A1 pulley. It will lock the digit in a certain position, but in grade 3 the condition is still passively correctable. In grade 4, the condition is locked and fixed, and it is no longer passively correctable. So, for this classification, it is a good to know classification. Usually in exams, people will want to know how well you know the topic and how can you classify the condition. And a green classification would be very useful for them. So, the next would be diagnosis. To make a diagnosis of trigger finger, you only need a history taking, a good history taking, and a good physical examination. Additional examination is usually not required. For history taking, you may find various symptoms such as finger clicking. There could also be pain around the distal palm region or directly follow to the A1 pulley, but sometimes you must be cautious when asking patients because there may be referred pain. The referred pain itself may show itself along the dorsal MCP or dorsal metacarpophalangeal or the dorsal proximal interphalangeal area. Next would be a locked finger. Usually the locked finger will be positioned in a flexed position. We must also remember about the normal anatomical tone or physiological tone of the muscles around the arm. As we all know that the flexor muscles around the arm is stronger, bulkier, and bigger than the extensor muscles at the arm. And these in turn will cause greater flexion force around the finger, hence the resting position of our hand. You could observe your own hand and see that your fingers are positioned in flexion rather than extension in resting position. And therefore, usually the finger that is locked is in a flexed position. After the finger is flexed, the nodes or that formed along the inflamed tendon will be caught proximal to the A1 pulley, and any attempt on extending the finger will be difficult. For the physical findings, usually you could only elicit pain. There should be tenderness along the A1 pulley, but sometimes in chronic cases where the tendon has inflamed, there could also be a palpable bump at the same location. Now, moving on to the management. For the management plan of any cases, there should always be a non-operative and sometimes an operative management. And non-operative management is almost always done first in any cases. The indication is for the first line treatment of trigger finger. The modalities for the non-operative treatment include night splinting, which could be done with slight flexion around 15 degrees of the metacarpophalangeal joint. You could also modify the patient's activity, suggest that they do more resting, they decrease the use of their hand, and they could also consume NSAIDs to reduce the inflammation. And the most popular medications that is given is steroid injection. Many surgeons have made their own cocktails and also published them, and you can find them in various journals. But one that I paid more attention to is this cocktail that is proposed by this certain author. He mixed 0.9 cc of lidocaine and also 0.1 of sodium bicarbonate, which in turn decreases the acidity that is contained by the lidocaine, and then he also adds up a soluble corticosteroid, 1 cc. And this cocktail functions as anti-pain by the lidocaine and also anti-inflammation by the corticosteroids. We must also pay attention on the types of corticosteroid that are used, because some corticosteroid may precipitate when mixed incorrectly. So it is advised that betamethasone, dexamethasone, or triamcinolone is used instead of other types of corticosteroids. We must also pay attention that injections in the flexor tendon sheath may be done 1 to 3 times, but once again, there must be intervals between these injections, because frequent injection using corticosteroid will induce spontaneous tendon rupture, which is found in several articles or several journals that has been published by various authors. Besides that, prognosis is a very frequent question. Patients frequently ask us, how well will I do after the injection? And it is very important to know that steroid injection usually works on non-diabetics, or in other words, it works better in a primary type of trigger finger instead of the secondary type. Okay, moving on to the operative. There are two basic techniques that are usually used, which includes the release of A1 pulley or the release of A1 pulley plus another procedure, which is the release of one slip of the FDS. This particular technique is usually used in pediatric population. In pediatric trigger finger, when you only release the A1 pulley without the release of FDS, usually the condition will recur. This is due to the high incidence of nota node formation, which is another name that is being given for a pathologic nodular tendon thickening that occur at the tendon itself. And if the slip of the FDS is not released partially, then there shall be recurrency in these cases. Although frequent release of the A1 pulley is not indicated, some authors prefer to do it primarily. The more commonly used technique is only the release of A1 pulley without any release of the FDS slip. The indication is of course done in cases where non-operative treatment has failed, and the technique includes an open or percutaneous type. For the open technique, we do an incision which may be various. It could be a longitudinal incision, oblique incision, and even transverse incision. But we should also pay note that we do not perform any incision that goes through the palmar crease, because this may in turn cause complications in wound healing, bad scar, and also contracture of the wounds. And besides that, for the open surgery, another important point that we should remember is that visualization of the digital artery and nerve is important to avoid inadvertently cutting these structures. Besides that, the distal edge of the A1 pulley and the proximal edge of the A2 pulley is sometimes incontinuous, and we can accidentally cut the A2 pulley, and this may have deleterious effect. Accidental cutting of the A2 pulley up to 25% proximally or distally may have no biomechanical impact on the functions of the finger flexor, but if you cut it accidentally more than 25%, then there shall be consequences. Next is the percutaneous technique that is now commonly employed, because this technique can be done in the office with local anesthesia. This technique involves insertion of a needle that is oriented longitudinally with the tendon. The skin markings, we do a skin markings to indicate the path of the flexor tendons, and then the needle is stabilized and the pulley is released from proximal to the distal. Elimination of a grating sensation as the pulley is cut all through the A1 pulley will indicate that the release has been completed. And a proximal to distal sweeping motion of the needle is used to release the annular pulley. Okay, after you have done all of those things and the patient comes to you, there are certain things that need to be paid notice to. The first is the complication. We always need to evaluate for any complications that may occur during the surgery or even after the surgery. For the complications that may occur during the surgery include accidentally cutting the radial digital nerve injury or A2 pulley accidental cut as depicted here. The knife may go through, the scissor may go through and cut the radial sided proper digital artery and nerve. And other complications include wound complication, because patients who had received corticosteroid injection 6 weeks, around 6 weeks before the surgery, may have wound complications such as delayed wound healing, and it is better to wait for around 6 weeks after the last injection before you decide to perform any open surgery. The last would be the prognosis. Prognosis is generally good after open release of a A1 pulley. The triggering usually does not recur, but for injections, the curative rate is not as high as operative techniques. Some journals would state that the curative findings is only found in 60% of patients that has been given injections, but some authors may state a higher percentage, up to 80 to 90% success rate. Okay, that would be all for trigger finger. If you have any questions, please leave your comments at the comment column, and do like and subscribe my channel, The Orthopedic Tutor, for more videos. Thank you.